Assalamualaikum everyone. This is Dr. Yasir, uh, as Associate Consultant Urologist at Maruf Hospital, recently joined last month. So, can you hear me?
Yes, we can hear you, sir.
Thank you. Should we start now?
Yes, we can start.
Okay. So, today we're going to discuss hematuria, which simply means blood in urine. So, this is one of the most common complaints we see in our clinics, we see in our emergencies, and even in our in-house consultations. So by definition, the presence of blood in the urine, this could be alarming, and as well as it needs detailed investigations and a thorough workup, which we'll discuss in the upcoming slides. First of all, we should know quite a few common things which should be clear in our all minds, that if it is actually a true hematuria or it is something else, maybe a false positive or some other causes of just hemoglobin of blood in the urine and no true RBCs. This could be hemoglobinuria due to some hemoglobinopathies and otherwise in some oncological diseases, and myoglobinuria, which can come maybe due to rigorous exercises and those who do quite strenuous activity. Anthocyanin in beets and blackberries, yet as a food component, this can cause reddish urine, chronic lead poisoning, mercury poisoning, and phenothiazines as drugs taken, and rifampicin yet can cause orange to reddish urine. These are a few common causes of reddish urine, but it's not hematuria. So this could be macroscopic, which is gross, otherwise called visible hematuria, and could be microscopic. Both are the same and needs investigation. It could be symptomatic, could be asymptomatic, with or without proteinuria. We'll discuss the significance of proteinuria in the upcoming slides, and we'll discuss the difference between macroscopic and macroscopic in the upcoming slide as well. So it could be initial, which means if the blood is coming before urination, and the terminal one, as its name indicates, it could be the one when we are done with our voiding at the end. This could be terminal, and total or mixed is the one which comes throughout the urination. So what we infer with this initial, terminal, total, usually initial one is due to urethritis, the terminal one is commonly due to prostatitis in males, and total could be due to any malignant process, maybe TCC bladder or maybe upper tract uterine carcinoma. So this is a bit of significance in knowing and in asking the patient about if it is initial or terminal or total. So to classify the causes of hematuria, this could be medical and urological. Medical means mostly of nephrological origin or glomerular origin, and urological will discuss the workup of both separately, and both needs to be managed separately. So medical causes include nephrological, IgA nephropathy, maybe post-infectious. There is a list of glomerulonephritis types caused by infective etiology or maybe any autoimmune etiology. Apart from nephrological or mainly glomerular causes, this could be systemic diseases, maybe coagulation disorders, and list of other hemophilic syndromes, anticoagulant disorders, protein S, protein C. And like we need to rule out or rule in the cause of hematuria. So we should not just focus on any tumor, like just tumors can cause hematuria. No, it's not true. We should exclude all possible causes, including nephrological and systemic causes. So coming to our main focus of today's presentation, which are urological causes. So then these can be caused by cancers of bladder, kidney, and stone. As we see in our clinics, it's one of the most common condition we see in the clinics. Stone can be in the kidney, urinary bladder, wherever it is, it can cause hematuria. Infections, and this could be bacterial or parasitic in some endemic areas, maybe in Egypt, which is schistosomiasis. Inflammatory conditions include drug-induced, maybe cyclophosphamide given in some malignancies. It can cause hemorrhagic cystitis and interstitial cystitis as well. Trauma can cause hematuria if there is some grade 3 to grade 4 kidney injury or any bladder urethra injury. In elderly age group, we see BPH as a common cause of hematuria in males, renal system diseases, vascular malformations. This can cause hematuria. So there is a question: is microscopic hematuria always abnormal? No, it's not the case. We can see a few RBCs in urine of normal people as well, and especially those who do strenuous physical activity like soldiers. There was a study on soldiers which showed soldiers have 40% of those can have microscopic hematuria on at least one occasion and 15% on 2 or more occasions. But this doesn't mean that we should not, do a complete workup. We should do a complete workup. And if that is negative, then we just can reassure the patient that like it's not due to any dangerous pathology, but not doing without complete workup. So there is another entity called transient hematuria, which can be caused by rigorous exercise, as we discussed earlier, maybe due to sexual intercourse or menstrual contamination. So to start with the diagnostic process of hematuria, as with any pathology, it starts with history. We have to, look for age and gender, if patient is smoking or not, and smoking is one of the most common causes of hematuria and TCC bladder, along with RCC and upper tract nasal carcinoma. As we discussed earlier, schistosomiasis in some endemic areas can be cause of hematuria. Occupational exposure to certain carcinogens, those who are working in dye industry, working in paint industry, there are certain aromatic amines which can cause hematuria. So drugs like NSAIDs, maybe one of the most common drugs taken in our part of the world without any prescription, and cyclophosphamide. So we should first ask for the simple cause of hematuria. This can be due to UTI or stone. And for these two basic entities, we should ask for pain, fever, dysuria, frequency, or any history of stone passage, any history of clots, as it suggests extraabdominal cause. So history of any recent upper respiratory tract infection can suggest post-infectious glomerulonephritis. So information about exercise, menstruation, recent interventions, including catheterization or passage-defining calculus. Like, the purpose of all these questions is as we have to rule in or rule out different causes of hematuria, as we discussed in the previous slides. So when a patient comes to us and we ask about age and gender, so what's the significance of that question? Actually, different age groups have different common pathologies causing hematuria. For someone to be 0 to 20 years, it can be caused by acute GN, acute UTI, and any congenital urinary tract anomalies with obstruction. In the age group 20 to 40 years, can be caused by acute UTI, stones, bladder cancer, although less likely before 40, but yet we have seen patients in clinics. In 40 to 60 years, men can have bladder tumor, stones, acute UTI. The same goes for women. And over 60 years for men, BPH comes as a common cause, apart from bladder tumor and acute UTI. So what are the risk factors we discussed? Smoking and occupational exposure to certain chemical dyes, history of gross hematuria previously or in a family, as this puts a patient in high risk. And someone who is more than 40 years, yes, there is a predisposition to oncological processes going on after 40 years. So this is a bit of general physical examination to look for any signs of systemic diseases, any nephrological origin disease, or any abdominal mass if we can find. And we should never forget to examine the external genitalia. At times, we find some very benign causes causing hematuria, including meatostenosis, phimosis, and urethral discharge, hinting towards any UTI or any STI. Lab workup starts with detection hematuria on dipsticks. If you find any hemoglobin urea or hematuria, then needs to be confirmed by urine microscopy, which is a urine complete examination. It should be a fresh specimen. And if we see pyuria suggests infection, RBC cast, they can suggest glomerulonephritis, or dysmorphic RBCs even suggest renal origin disease. Urine culture should be done. It should be to complete the nephrological workup, should 24 hours urinary protein, and we should check for a low serum complement if it is there, as it suggests all the nephrological causes of hematuria. ANA to look for any SLE. Urine cytology, if there is persistent hematuria and we don't see any cause of urological origin on CT or flexible cystoscopy, then urine cytology is done. It is quite sensitive and quite specific for bladder, but not that specific for and sensitive for the upper tract. So in the imaging category of workup, renal bladder ultrasonography, enhanced CT scan, VCUG to look for any pediatric or congenital anomalies, and radionuclide studies to look for different split functions and other details. Ultrasound can detect stones, any inflammatory processes, any vascular malformations, and obstruction. But it can miss ureteric stones, and it can even miss small tumors, which we usually see on CT scan. Nowadays, CT is most widely done as a part of hematuria workup, CT scan with and without contrast. And to complete the protocol should be with delayed images to look for any filling defect. So in these images, we can see a stone which is causing obstruction right here. And there's a huge tumor from the left kidney. And here we see a bladder tumor. These are common causes of hematuria we see in our clinics. IVU was once it used to be done commonly, but now it has largely been replaced by CT scan. But it can yet show a filling defect, which can be due to a stone or a tumor. MRI is less commonly done as a routine workup of hematuria, but it is an alternate for children and for pregnant ladies and someone who is having a contraindication to iodinated contrast media. But yes, it can show tumors, stones. VCUG is commonly done to look for any congenital anomalies, any dysplastic kidneys or duplex systems, VUR, or any PUV. These all things, these all entities can be cause of hematuria. But yes, it's not a routine part of our hematuria workup. Cystoscopy. Nowadays, After image like CD, cystoscopy is also a mandatory, minimally invasive, you can say, part of investigation process of hematuria, and highly recommended for high-risk patients. So here we see a bladder growth, which is papillary TCC bladder. Biopsy is rarely done in the evaluation of isolated asymptomatic hematuria, but we do it with nephrology team for significant proteinuria, any CKD, recurrent persistent hematuria, and if we have not found any other cause or any serological abnormalities like DNH, ANA or dsDNA or any abnormal complement components or any family history of ESRD. So how we do approach to hematuria, like it's just a summary of what we have discussed in the previous slides, like history and physical examination, then urinalysis. If there is HB, but if there is hemoglobinuria but no RBCs, then search for other cause of red urine, like any myoglobinuria, or if we are taking any drugs causing this. Then if we have RBCs with hemoglobin, then check for RBC morphology, which suggests if it is glomerular or non-glomerular. So how we do approach to non-glomerular causes in pediatric age? If we do urine culture, if it is positive, then this could be caused by any infective cause, and coupled with urine culture coupled with renal ultrasound plus minus VCUG. If these are abnormal, as we discussed in previous slide, this can hint towards any PUVs, multi-cystic dysplastic kidneys, any PCKD, VUR, or any renal vein thrombosis. So this is again, if it is a glomerular cause, then it goes towards the nephrology side. We'll not discuss it in detail. And this is a bit of a massive slide. Sorry, it's not that clear, but it's just a summary of what we have discussed earlier. So to summarize and to give a take-home message, the passage of blood in the urine is always alarming and investigation is warranted. Urine complete examination should be carried out in all cases of positive dipstick test. Evaluation must be started with detailed occupational, family, and medical history. Medical causes should be excluded before urological consultation. Ultrasound and CT scan are much helpful for evaluation of patient with hematuria coupled with cystoscopy. So, urine cytology and cystoscopy are included in the workup for high risk patient group. And this is the last take-home message. We do complete workup in all patients with hematuria, which is a true hematuria. But we don't find any abnormality in about up to 70% of patients with asymptomatic microscopic hematuria, despite we have done all these conventional and invasive investigations. But if we stop doing complete workup, then we will miss about that 20 to 30% of patients which are having any urological cancers. And if we miss those patients at some earlier stage, then we'll be seeing all these patients with advanced diseases, with metastatic diseases, which is not acceptable. So this was a take-home message. Hematuria should be considered as TCC, bladder, or upper tract unless proven otherwise. This is the last take-home message for all of us. And thank you all. Any questions? Okay, thank you. Thank you all.